So with this, I'll turn it over to David Hyman, who will begin the afternoon session in talking to us a little bit about how do we use pathology reports, specifically genetic sequencing results, to inform decisions about immune checkpoint blockade therapy. Thank you, David.
Thanks for having me. Hopefully this will be a nice overview. Here are my disclosures. So I think it's not news to anybody in this room that checkpoint inhibitors have become a kind of cornerstone of prescribing for oncology these days. There's now 14, I think this was in 2018, so there's more now, but at least 14 unique indications, 6 approved checkpoint inhibitors. And actually, I think we've just crossed the Rubicon of 50% of patients with advanced cancer by prevalence have a cancer type and an indication for checkpoint inhibitor use. And this is from a article published this year in JAMA Open Network, which basically made the point that although approaching 50% of patients have an indication for checkpoint inhibitor use, the actual rate of response is somewhere between 15 and 20%. Now, I look at that and I say, well, that's pretty good. One class of therapies that 15 to 20% of cancers respond to. That's pretty amazing, especially when those responses are durable. But I think we all recognize that there is still a gap here. And the question, of course, is whether there's patient selection strategies that could aid in the prescribing of these drugs. And really the focus of my talk is on next generation sequencing. Of course, there are other orthogonal methods, specifically immunohistochemistry, which are now routinely used in several disease settings to select treatment for these patients. And this is again from a recent review a couple of years ago showing all the different kind of hallmarks of response to immunotherapy, or that condition response to immunotherapy. But what I really wanted to focus on are the hallmarks that might be tractable through next generation sequencing profiling technologies. And I'm going to take these one at a time. But before I go into the actual data itself, I thought I'd talk a little bit about the testing. There is now a broad array of testing that's available for patients. At Memorial, we use a test called MSK-IMPACT, which tests 468 genes. And this is what we call an exon capture panel. So what capture technologies do is they basically use baits to capture just a segment of the genome and then sequence it deeply. The other technology that's used fairly commonly in the community setting is amplicon-based technologies, which the main difference here is that amplicon-based panels tend to be somewhat smaller in size. They're not optimally equipped to detect fusion events or copy number alterations. These are really just looking for mutations. And they're not usually suited for identification of other broader genomic features like microsatellite instability or tumor mutational burden. But these are tests that you're familiar with, like Foundation 1. There are multiple onco-panel tests, which are capture-based tests. And then I think increasingly what we're going to see is the approval of kit-based testing. So these are tests where your pathologist could basically take a pre-established kit with a pre-established informatic algorithm, and just run out the reports. And I think what we'll see over time is that these large central labs will continue to be high volume, but a lot of this testing will move to the local centers and kind of be democratized in that way. So I think in general, there's going to be multiple avenues to obtain this type of testing for your patients. And these are constantly evolving tests, but the common features really are panel sizes in the several hundreds of genes, and these capture-based technologies are really emerging as the gold standard. And what we're going to see, that's really what I'm going to focus my talk on. So this is the outline. I wanted to talk to you a little bit about tumor mutational burden, a little vignette internally to that about neoantigen prediction, microsatellite instability, individual mutations which may predict response, and then just broadly mention other things like signatures. So tumor mutational burden is obviously had a lot of press. This is a paper by Ellie Van Allen that was published in Science in 2015, looking at the ability of tumor mutational, or the correlation of tumor mutational burden with outcomes. You can see here, this is the survival of patients following checkpoint inhibitor therapy. and this is their progression-free survival. And what you want is patients that live a long time and have a long progression-free survival, and those are annotated as patients who derived clinical benefit. And what you could see is that there is a clear trend towards increased tumor mutational burden in patients that had benefit. So you can see the green versus the gray or yellow bars. Now you can also see, and I want to point this out, and this is one of the things that makes this challenging to implement clinically, is you can see that although these box plots have differences between them, statistically significant differences, you can see a huge amount of overlap. So at the lower range of this box plot, there's a lot of intersection with patients that don't derive or have minimal benefit to checkpoint inhibitors. So a ton of overlap here. And neoantigens, basically what this is an effort to sequence every gene in the exome and actually predict which ones would form neoantigens expressed in the patient's MHC class. These are bioinformatic predictive algorithms, and they also roughly correlate, but it's the individual predictive algorithms really are not robust at this point, and so it's difficult to correlate whether a specific predicted neoantigen really acts as a neoantigen in that individual patient. So think of neoantigen prediction as an attempt to refine just the raw mutational load and sorting the mutations that we think are more immunogenic from those that may not be immunogenic. But this, again, is really in the realm of research. And actually, because most of these neoantigens are not in classic cancer genes, we actually can't use those targeted panels. So none of these tests are actually suitable for the neoantigen predictions because they don't have the full genomic content that's required for those algorithms. Tumor mutational burden has been evaluated as a biomarker in the context of dozens of immunotherapy clinical trials. It's impossible to cover every one, but this is a review from Tim Chan showing many of the clinical trials that have used tumor mutational burden as a potential selection or stratification factor. This was a paper by Matt Hellman, one of our colleagues here, a phase 3 study of Checkmate 227, which was a study, a multi-arm study. What's shown here is in patients with untreated non-small cell lung cancer randomized to ipi-nivo versus chemotherapy, and these are patients that were TMB high based on tumor testing with a threshold of 10 mutations per megabase. And you could see a difference in outcome of chemotherapy versus nivo-ipi. And this actually was initially submitted for approval on the basis of these results. But then about 6 months later, there was a press release by BMS indicating that an updated survival analysis actually had a material change and that it lost significance in this subgroup, and ultimately the supplemental BLA was withdrawn. So the application for approval from Checkmate 227 based on this TMB cutoff was ultimately withdrawn and is, to my knowledge, not currently under regulatory consideration. This is actually an interesting analysis from another lung cancer study with MYSTIC. This is an AstraZeneca study. And the design of this study was looking at multiple different checkpoint inhibitor combinations. So Durva, the PD-L1 inhibitor, Durva-Tremi, so PD-L1 and CTLA-4, versus platinum chemotherapy in untreated non-small cell lung cancer. This is also a multi-arm study with more than 1,100 patients randomized. And what's interesting is that in this study, you can see a biomarker analysis using blood-based TMB. So this is actually establishing TMB using a liquid tumor biopsies. This is not a tumor-based test. And this was actually a test developed by Guardant. It's not the Guardant 360 panel that you order clinically now. It's what they call Guardant Omni. And the distinction there is the Guardant 360 panel is a more limited content panel. And really to begin to get tumor mutational burden, you need to have a panel of at least 1 megabase in size. So this is a much larger panel. It's not yet routinely clinically available, but it is a test that they have been developing for several years now. And using a different cutoff of 20, actually you can see a clear difference between outcome with chemotherapy versus checkpoint inhibitors. And actually, this actually performs better, the blood-based testing in the context of this study, than tissue-based testing. One of the other things worth noting about TMB is that it's actually, it's sometimes difficult to report TMB values on patients because of low tumor purity samples. So the rate of, if, for example, going back to Checkmate 227, I think only 58% of patients in this study were actually evaluable for TMB status, and therefore it's, there's an attrition rate of evaluation of the biomarker, and a slightly, you can see here that's also the case with blood-based TMB, where there's a number of patients who are not evaluable by the biomarker. So when you some considerations to summarize the TMB experience, I didn't mention this, but tumor mutational burden is best thought of as a signature. It's not exactly a signature, but what I mean by that is that it's not comparable from test to test. So depending on the exact content in your assay, the TMB value that you get from one test may not be exactly comparable to another, and there's no completely harmonized approach about how you report TMB. So for example, do you report non-hotspot mutations, or do you count recurrently altered mutations like KRAS G12C mutations in your calculation of tumor mutational burden? And actually, the Friends of Cancer Research, which is, as you know, like a patient advocacy group, it has a big flagship project looking at harmonizing tumor mutational burden reporting across multiple clinically validated assays. So, you know, what is a threshold on one test is not necessarily cross-applicable to another test. There's also, as I mentioned, big differences based on the analyte sequence. So tumor versus blood can give you very different results. Obviously, blood kind of integrates mutation calls across multiple tumor sites that contribute cell-free DNA to the blood, whereas tumor, you're just looking at the individual site that you biopsy. There's lack of clarity over the appropriate cut point. So for example, in some of the tumor types that are associated with lower tumor mutational burden, like breast cancer or kidney cancer, what is a high TMB kidney or breast cancer? Can we really use the same cutoffs that we use, for example, in the higher mutational load tumors like melanoma? And I think where we are now as a field is that this correlates with outcome, but it is not yet a clinically validated biomarker. I think that's really the best summation of the evidence right now. I'm going to just go through, because I realized it was only a 15-minute talk, so I'll go very quickly here. Microsatellite instability is something that you're all familiar with. This can be defined on the basis of a mismatch repair staining by immunohistochemistry, but actually next-generation sequencing tests are quite good tests for the detection of microsatellite instability using a variety of computational methods. And what you can see here is actually an analysis done in the Memorial data set of tens of thousands of tumors. And what you can see here is the cancer types that we all know canonically harbor mismatch repair deficiency, like colorectal cancer and endometrial cancer. You can identify a number of patients with these blue dots, which are microsatellite unstable tumors, but you can actually see a lot of patients that have collectively, in aggregate, that have microsatellite unstable tumors, but tumor types for which microsatellite allele-specific testing, like mismatch repair immunohistochemistry, is actually not routine. And these are candidates for immunotherapy on the basis of this data set. As you know, the first kind of tumor-agnostic approval was for pembrolizumab in MSI-high cancers, and you can see kind of broad activity and deepening activity over time with durable benefit. And so the detection of this group of patients might be served by established clinical testing paradigms doing immunohistochemistry, but it's really these patients that we're increasingly picking up on next-generation sequencing tests. And now pretty much all of the broader panel-based tests are reporting this out. I just want to mention that these biomarkers have a high degree of have a high degree of overlap. So this is a data set that was published recently. You can see about 2,500 patients in this data set were PD-L1 positive. A subset of those are PD-L1 positive TMB high. A subset of those are both PD-L1 positive TMB high and MSI high. And if you kind of zoom out of that a little bit, you can see that these circle over here are the MSI. These circle over here are the TMB. So nearly all of the MSI are TMB high, but many of the TMB high are not MSI high. So another way of saying that is that there are multiple causes of driving high tumor mutational burden that are not microsatellite instability, and that all of these genomic-based biomarkers have some degree of overlap with PD-L1, but are largely orthogonal tests. So PD-L1 is really a different biomarker than these genomic-based tests. Just mention 2 other anecdotes, and then I'll stop. STK11, so obviously one of the appealing things to do is to say, let's take a step back from these purely signature or larger epigenetic genomic changes and say, can we identify specific genomic alterations or patterns of alterations that are associated with response or resistance to checkpoint inhibitors? And one tumor type in which this has been explored in a fairly mature manner is KRAS-mutant non-small cell lung cancer, where a combination of STK11 and LKB1 mutations have been observed to drive resistance to, or be associated with resistance to immune checkpoint inhibitors. And you can see here, this KL group is the group that is STK11, LKB1 mutants, and you can see the response rates to checkpoint inhibitors is around 5% across multiple independent cohorts. When you have just an STK11 mutation with P53, you do much better, and when you have just an STK11 mutation with no P53, you also do okay. So it's really this combination of KRAS mutant non-small cell lung cancers with this dual mutational pattern that appear to generate resistance. And what you can see here actually is when you do H scores, which are quantitative scores for PD-L1 status, you can see that PD-L1 is nearly universally negative in these tumors. So this actually may be a genomic pattern which manifest in the immunohistochemical staining by PD-L1 in these patients as a kind of biologic basis of insensitivity in these patients. This is another anecdote that's been emerging from the field. This was another paper by Ellie Van Allen published in a discovery set in Science. There have been some efforts to clinically validate this biomarker since, although it's not quite, this is not considered routine. And PBMR1 is a component of the SWE/SNF pathway. So this is a pathway that's responsible for chromatin remodeling and gene expression. And the theory is that some of these low mutational burden tumors like renal cell carcinoma may have errors in their chromatin remodeling that allow aberrant expression of genes that lead to immunoresponsiveness. And this was one effort to boil that down to the presence or absence of an individually mutated gene, in this case PBRM1, and you can see that it did appear to be associated in this data set with outcome, although very small numbers here. You can see this is a discovery set of less than 50 patients. And there's been, I don't have time to show you, but there's been some papers recently in JAMA Oncology, for example, validating this in the context of a phase 3 study. And I'll just mention that BRCA is another one that people have thrown around as a potential biomarker, and really the jury is still out on this. This was a pan-cancer analysis done at Memorial, and we did not identify germline or somatic BRCA mutations after correcting for tumor mutational burden as an independent predictor of response. As the tumor mutational burden rises, the number of deleterious mutations in BRCA rise, and so there is obviously a correlation between BRCA status and tumor mutational status, and I think one of the broader lessons here is that as we look to correlate individual gene mutational status with outcome to immune checkpoint inhibitors, we need to be sure to control for the factors which we know affect outcome, like tumor mutational burden. So really, this is my conclusion, and I think it's a simple take-home message. The only currently clinically validated test is MSI, and we don't think it matters whether you detect your MSI by immunohistochemistry or next-generation sequencing. There are multiple investigational uses for DNA-based testing, for biomarker selection, for immune checkpoint inhibitors, but the majority appear to be enrichment strategies and are not currently clinical biomarkers, and I think that's a really important distinction. And it's unclear whether ultimately these targeted-based panels will be sufficient or whether whole exome sequencing might be needed to really refine these from these enrichment strategy assays to really clinically robust assays. So that's kind of an unanswered question for the field. So thank you so much for having me, and it's a pleasure to have you here at Memorial.
We have time for a couple questions for David from the audience. So David, one question I have is about kind of intra-patient intertumoral heterogeneity. I know from classic driver mutations, BRAF or KRAS, we would assume that all the tumors would have that mutation, but what do we know kind of about either neoantigens or what we might get on these NGS reports if we biopsy one site, how reliable is that? I think you made a comment before that blood might be, a good way to kind of get the whole portfolio of all of the tumors, but what do we know about that relevance in this context?
Yeah, so there's definitely been some papers that have looked at whether the neoantigens being truncal, so early alterations, or late matters in terms of response. And I think that this is another area where it would seem intuitive that that latter is true, but it's not 100% clear. So there was a paper by Charlie Swanton that looked at whether non-truncal neoantigens were associated with partial or mixed responses or eventually treatment failure, and found that it was. But I think in the setting of MSI, for example, actually a lot of these neoantigens occur late and through branched evolution. And so it might be that in some of our patients, they're actually, these immune checkpoint inhibitors are actually stimulating responses against a lot of private neoantigens that are not shared as a common event across all tumor sites. So I don't know, because we're not using this information to prescribe checkpoint inhibitors day to day, I don't know how much we lose or miss by doing this. I do think, though, that there's a biologic rationale for why certain methodologies like blood-based TMB measurement may actually be a more accurate measurement for this type of purpose of genomic complexity of tumors than just a tumor biopsy. So it might actually be that some of the features of plasma-based testing are uniquely suited for categorizing the genomic complexity of a cancer in a way that an individual tumor-based test is not. I just think we need to integrate these biomarkers into our phase 3 studies to really answer these questions.
Other questions? I think the point that you made about the MSI sensor, kind of identifying other Pembro or PD-1 candidates is a really important one. So it's something that, as we get these NGS reports back, we should look into, in addition just to knowing to test endometrial and colorectal cancer by IHC to identify these patients that might be candidates for checkpoint blockade.
Yeah, and I think you have a question and I want to answer it, but just one other follow-up to that, which I didn't mention and I think is important. So, if you identify a patient that is MSI high by tissue-based testing, we would absolutely recommend treating that patient with a checkpoint inhibitor. Obviously, you have to consider what the other options for that patient are. But there are blood-based tests which are capable of reporting MSI status, and when they're positive, we think that they're reliably positive, but there's a high false negative rate because if you're a low shedder or if you're having some response to current therapy, so we really think of MSI-based blood testing as being associated with true positives, but the negatives can't be counted on. So if you have a cancer type like colorectal, which has a fairly high rate of MSI high, or endometrial, we wouldn't consider that to be sufficient testing if it was negative for MSI status.
I have a nomenclature question.
Yeah.
So we do next generation sequencing and look at different genes and find out what drivers there are and so on. So I tend to slip into the word, we'll do a genetic study.
Yeah.
But then there's other people who say, no, this is a genomic study. So how do you weigh in on the right phraseology?
Yeah.
Or should we even be just saying, if we just say NGS and avoid the controversy?
Yeah, I don't know that there's a right between genetic and genomic. I think what confuses patients, and I think what you're alluding to, is are you testing them for things they inherited and can pass on to their children or not? And so sometimes people call it genetic profiling or molecular profiling, but what I just try to tell patients is that this test that I'm ordering is to look for treatment for your cancer. It's not, well, it can sometimes be depending on the test you're ordering, but most of these tests I highlighted it's not meant to identify why you got cancer, and the mutations I'm talking about are not the kind that you pass on to your children or you inherited from your parents. So we're really looking for things that can direct treatment for you.
So that suggests a bias towards this being genetic testing rather than genomic, which implies germline testing, right?
Yeah, I mean, I don't know that there's enough agreement upon this different nomenclature that genetic or genomic means germline or somatic. I tend to speak in looking for inherited or acquired mutations. So is this something you got from your parents or can pass on to your kids, or is this something that occurred in the tumor after birth?
Yeah, so I'll just tell them it's a false question. Get
Yeah.
past it.
Yeah, I don't know. I don't know if I can solve
Nobody
this
knows the
dilemma
answer to
for
this.
you. Yeah.
Thank you, David. It's a
Thanks.
great discussion. I
Thanks.
appreciate your time today, and thank you for the questions.